Hello friends, good morning and welcome to the day 2 of ENT. I hope you revised a couple of things we did last time of the larynx. And yesterday was a holiday for you, Tuesday. And I hope you remember Tuesday. It means 12 hours of self-study and I hope you did that. If you could not, due to any reason, let us not our yesterday spoil our today. Because this is the biggest problem we are having as human beings. Hello friends, good morning and welcome to the day 2 of ENT. I hope you revised a couple of things we did last time of the larynx. And yesterday was a holiday for you. The biggest problem being a human is that we don't leave our yesterday and we keep predicting our tomorrow also. So our human brain is absolutely a wonderfully developed you can say software and hardware after millions of years of evolution. So now this structure has got an immense property of recalling what has happened wrong in the past, and it has got a very beautiful sort of function of predicting what can happen in the future. Generally, we keep predicting something wrong happening in the future. What if I score 149? What if I do not pass this time again? And these are genuine fears, actually. You know what? I can understand that, but that's the way human brain is actually, sort of crippling us, I would say. It is oscillating between yesterday and tomorrow, but we are forgetting today. Today, human brain is oscillating between yesterday and tomorrow. Yesterday, something has gone wrong. We could not perform to the best of our abilities. We did not fulfill our promises. So we have a guilt today morning. I understand. And we have that guilt of not doing the right thing in the past. And we have a very huge, imaginary power to really foresee that, okay, what can go wrong in the future. Now, this oscillation between yesterday and tomorrow is actually not your problem. It is a human race function. That's the way human race function. Don't think that only you are doing it. But you know what? This is a machine. This is a human body. Human thing is a machine, and every machine has got a manual into which we can really read that how to put this machine to best of its use. Now, this machine has an inherent property of oscillating between yesterday and tomorrow. But if you are ready to learn an art of focusing on today is on your hands. Today, this is the day in your hands now. That okay, what I can do maximum to contribute to my possibility of success in the future is today. So today we have an opportunity to learn ENT and learn ENT and learn ENT. Come here. This is largely the what you always see these guys, faculties teaching you guys. And you think they are the real heroes. The real hero are these people. You know what? Real heroes are the people who actually support us, who really, can you imagine that I just started, from home. I couldn't have a breakfast because I was running late and I can't start class, late actually. It's my bad habit, you can say. 9:30 means generally 9:39 for me. But Lalji is like, too kind, I would say. You'll bring tea for us over here and they are the real heroes. You know what? Believe me, they are the real heroes which make us work the way we work. Thank you, Lalji. Thank you, Lalji. So, I think the main focus you should have today that let's learn as much ENT as possible. I hope last time you learned larynx and I got a lot of emails and a lot of messages. Thank you very much for those loving words, and I'm really very humbled by hearing those words. I'm glad that you enjoyed the session. I'm glad you learned, and today let's learn further now. So today, first stop will be pharynx, then we do the nose and sinuses, and then the later part we start the ear. And tomorrow, the third day or the final day of ENT, we do the whole day ear. That's how it goes actually. Okay, so let's start with pharynx. Start the day with a smile, my dear friends. Start the day with a smile. That's very important. You know what? I know we are struggling, but you know what? It's okay. No problem. Okay. So pharynx. What is pharynx, everybody? Open up your notes again. Pharynx. I think pharynx must be second topic in your notes. Now, what is pharynx, beta? Everybody, open up the pharynx topic. 1 second. Let me tell you the page number. Yeah. The pharynx page number is 39. 39 page number. Pharynx, the page number is 39. Let's start pharynx, beta. What is pharynx? Pharynx is a fibromuscular tube from skull base to C6 vertebra. So pharynx is a tube, beta, tube from skull base to C6 vertebra, beta. Look at me, beta. Look at me. From skull base. What is my skull base? My hairline, beta. My end of the hair actually is roughly my skull base. And what is C6 vertebra? C6 vertebra is the end of my neck, nearly end of my neck. C7. End of my neck, beta. So look at me, beta. From the skull base to C6 is my neck, And in the neck, whatever hollow column is there is called pharynx, beta. Very simple concept. In the neck, whatever hollow column you have is your pharynx. Look at everybody, look at your hairline, look at the end of your neck. What is between the skull base and C6 is your neck, beta. And neck has got a hollow column, and then that hollow column is called pharynx, beta. So pharynx is a fibromuscular tube from skull base to C6 vertebra. One second. Hello. Is it on? Okay. Now, the muscular tube means it has got some muscles, and you see this picture, and there are muscles over there, beta. There are muscles over there, and let us understand this picture first, then we going to really revise it again. Now, when I say fibromuscular tube, firing the fibromuscular tube in the neck of human beings. Now, muscle means there are three muscles. What are the muscles? Constrictor muscle, beta. Constrictor muscles, and just understand first of all, and then you will see this picture, you will understand everything. There are three constrictors: superior constrictor, middle constrictor, inferior constrictor. Okay, pharynx is a fibromuscular tube. What type of muscle it has? It has got constrictor muscles. Okay, and constrictor means number one SC. SC means superior constrictor. MC means middle constrictor, and number three IC means inferior constrictor. Superior constrictor, middle constrictor, inferior constrictor. This is skull base. This is C6 vertebra. Can you see C6 over? This is your pharynx, beta. This is your pharynx, beta. Okay, from skull base to C6 is your pharynx. It is a fibromuscular tube. It has got constrictor muscle, superior constrictor SC, middle constrictor MC, inferior constrictor IC. Now let us see at the inferior constrictor, beta. Now inferior constrictor, look at screen, beta. Inferior constrictor has got two type of fibers. One are oblique fibers. They are called thyropharyngeus. TP means thyropharyngeus, and then circular fiber called cricopharyngeus, CP. TP plus CP is equal to IC, beta. Inferior constrictor, once again speak with me. There are three type of muscles in the pharynx, and all of them are constrictor muscles. What is the first muscle? SC. What is SC? Superior constrictor. Bolo beta, are you speaking with me? Number two, MC means middle constrictor. Number three, inferior constrictor has got two type of fibers: oblique fibers and circular fiber. The oblique fibers are called thyropharyngeus, and circular fiber called cricopharyngeus, beta. Thyropharyngeus and cricopharyngeus. Everybody, TP and CP, beta. Thyropharyngeus, oblique fiber, TP, thyropharyngeus, circular fiber, CP, cricopharyngeus. Thyropharyngeus plus cricopharyngeus is equal to inferior constrictor, beta. Okay. Now, can you see between the thyropharyngeus fibers and the cricopharyngeus fibers, there is a triangular area which has no muscular layer, beta. This triangular area has got no muscular layer. Okay, and this area is called Killian-Dyson's. Very famous question of your exam. Killian-Dyson is the ultra, put a star over there. Killian-Dyson, what is KD? Killian-Dyson's is a triangular area between thyropharyngeus and cricopharyngeus, and Killian-Dyson's has no muscular layer, beta. Can you see? There is no muscle in Killian-Dyson's, beta. It's a weak area. It's a weak area, means it's unsupported area. It means that there is a possibility of herniation of mucosa out of this area. And that is called pharyngeal pouch, or surgery question, Dr. Vineet's question, Zenker's diverticulum. Zenker diverticulum, also called as pharyngeal pouch. So Killian dehiscence is the site of formation of Zenker diverticulum or pharyngeal pouch. Lot of question here, beta. Now one more thing over here you see. Let us finish this diagram, beta. Pharynx is from skull base to which vertebra? C6 vertebra, beta. And when pharynx ends, esophagus start, beta. Okay? Like pharynx and what start here? Esophagus start. Esophagus start, beta. Am I clear, beta? Esophagus start. Okay? Fine. So the basic thing is very simple, beta. Okay, now all of you read the notes over there, beta. Everybody open up the notes. Come over here, beta. It has 3 constrictor muscles. 3 constrictor muscles, beta. Did you eat something? Did you eat something before the class or no? Please do take care of your health also. You know, even I missed my breakfast today. You know what? We are not ideal people. You know, we do something wrong things, and I couldn't have my breakfast. I was just running, and if you don't have any time to eat, like what did I do today? I just had 1 handful of almonds and took that while coming in that cab. Actually, do that. Just some maybe boiled eggs, maybe almonds, maybe walnuts, maybe a banana. That's not a bad idea. Okay. Superior constrictor SC, middle constrictor MC, inferior constrictor IC. Beta. Everybody, inferior constrictor has got 2 type of fiber. What are 2 type of fiber? Number 1, read, beta. Oblique fiber called thyropharyngeus. Circular fiber called cricopharyngeus, beta. Okay, fine. Now, Killian dehiscence. It's a triangular area in inferior constrictor muscle. Okay, between the fibers of, fill in the blank, beta. Between the fibers of, everybody write down, thyropharyngeus, and cricopharyngeus. Thyropharyngeus and cricopharyngeus. Thyropharyngeus and cricopharyngeus. Okay. Very important question. Put a star over here. Okay. Okay. So Killian dehiscence is a triangular area between the fibers of thyropharyngeus and cricopharyngeus. This area lacks muscular support. Very good. This area lacks muscular support. Therefore, it's a weak area of pharynx. Okay. Okay. It's a site of formation of Zenker's diverticulum. Zenker's diverticulum, also called pharyngeal pouch, beta. Zenker diverticulum, also called as pharyngeal pouch. Zenker diverticulum, also called as pharyngeal pouch, beta. Okay. So I hope you know this topic, Zenker diverticulum, beta. Zenker diverticulum or pharyngeal pouch, beta. Okay. Because this area has no muscular layer. Killian dehiscence has got no muscular layer. It is a weak area. It's a triangular area. So this is a site of formation of which diverticulum? Zenker. Z-E-N-K-E-R, surgery topic, beta. Zenker diverticulum or pharyngeal pouch. Ultra famous question, beta. Killian dehiscence is a super duper favorite question. And second significance is, it is possible site of perforation during rigid endoscopy. When you're doing endoscopy in a patient, please be careful in Killian dehiscence area. Why? It's easy to perforate in that area. Why? Because this area has no muscular layer. That's why it's a weak area of pharynx. Is the point clear to all? Okay. Now, everybody, let us see another topic now. The same diagram. Sinus of Morgagni. Sinus of Morgagni. Sinus of Morgagni, M-O-R-G-A-G-N-I, S-O-M. Where is sinus of Morgagni, beta? Everybody look at the first picture. This one. Can you see S-O-M written over here? Everybody go to the first page of pharynx. Can you see S-O-M, beta? Sinus of Morgagni. Can you see it is space between skull base and the superior constrictor muscle? This area. This Killian dehiscence is the space between skull base and which muscle? Superior constrictor muscle. Something is passing through, that is Eustachian tube. ET. Eustachian tube is passing through that. ET. Eustachian tube. And there is a muscle around Eustachian tube that is also passing through sinus of Morgagni. Now look at your notes, but everybody. S-O-M. Sinus of Morgagni, it is a space between skull base and upper border of superior constrictor muscle. Once again, what is S-O-M full form, beta bolo? Are you speaking with me? Are you imagining that you and me are sitting together? I'm not an educator, I'm not a teacher, I am a friend of yours who is discussing ENT with you, who is revising ENT with you, who is understanding ENT with you, beta. Okay, fine. It's a space between skull base and upper border of superior constrictor muscle. What is SOM full form beta? Sinus of Morgagni. Okay, fine. What passes through sinus of Morgagni? Eustachian tube and one muscle. Which muscle? Eustachian tube and ET. Eustachian tube and which muscle? Tensor villi palatini muscle, also called as tensor palati muscle, passes through sinus of Morgagni. Okay, bache? Okay, bache, fine. Is it clear to all? Fine. Okay. Eustachian tube and tensor villi palatini muscle. There is a tube. There is a Eustachian tube. There is a muscle around the tube which open the tube. Which muscle? Tensor villi palatini muscle or tensor palati muscle passes through sinus of Morgagni. Passes through sinus of Morgagni. Okay, fine. Now, on the sidebar, please write down here. Sidebar, everybody please write a question here, beta. On the sidebar here, sidebar, please use sidebars, beta, to make summaries, to write down certain special points, to write additional points, so that you don't make the major body of the notes dirty, beta. Don't make them clumsy. This area, please keep it as smooth as possible. This area you might use it so that the notes are really clean and really, very, easy to revise again. Now write down most common site of, write down here, beta, MCQ, most common site of impaction of foreign body, most common site of impaction of foreign body in digestive tract. Most common site of impaction of foreign body in digestive tract, beta. Most common site of impaction of foreign body in digestive tract, beta. Can you see over here, beta? Most common site of impaction of foreign body in digestive tract, beta. Digestive tract is not aero tract, beta. Digestive tract is cricopharyngeal sphincter. Most common site of impaction of foreign body in digestive tract is which sphincter, beta? Cricopharyngeal sphincter. Cricopharyngeus muscle, beta. Cricopharyngeus muscle. At the level of cricopharyngeus, cricopharyngeus is what type of muscle? Circular muscle. Circular muscle make what? Constrictor muscle. They make what? Sphincters, beta. Sphincter. Circular muscle make what? Sphincters. So, most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter. Cricopharyngeal sphincter. Most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter, beta. Cricopharyngeal sphincter. Okay, in the bracket C6 level, beta. Cricopharyngeal sphincter in the bracket C6 level. So answer is most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter in the bracket C6 level, beta. C6 level. Okay, C6 level. And okay, and to find out this and to find out the exact site of foreign body, we need X-ray, AP view and lateral view, beta. To find the exact site of foreign body, we need X-ray. Yes, X-ray. Which view? AP view also and lateral view also, beta. AP view also and lateral view also, bache. AP view and lateral view also, beta. AP view and AP मतलब anterior posterior view and lateral view also, beta. Okay, bache. Can you see, beta, the AP view? Can you see a foreign body here, beta? AP view, and you would need a lateral view also, beta. Okay, bache. And you would see the lateral view also, because in the lateral view you see like this, beta. Can you see this? This is the lateral view picture of the coin, beta. Can you see coin in the esophagus? Okay, fine. This one, beta. So, which is vertebra, beta? C6. Can you see C6, beta? Pharynx is from skull base to C6. What is this level, beta? C6, beta. Okay. So, very easy question. Oh, pharynx is from what to what? Skull base to C6 vertebra. At the C6, which muscle is there, beta? The last muscle of the pharynx. What is the last muscle? Cricopharyngeus muscle. What type of muscle it is? Fiber it is. Circular fiber. I know circular fibers make sphincters, beta. Sphincters. So, the most common site of impaction of foreign body in the digestive tract is the cricopharyngeal sphincter. What is this level of vertebra? C6 level, beta. C6 level. C6 level, beta. C6 level, beta. Okay, bache? Fine. Is it clear to all? Okay, fine. I hope you remember this X-ray was there in your last exam also, beta. Okay, fine. Chalo. Let's go further, bache. Let's go further now. Now, next one, beta. Everybody open up this one. Pharynx has got 3 parts, beta. Pharynx has got 3 parts. Number 1 is nasopharynx. Number 2, oropharynx. And number 3, laryngopharynx, beta. Nasopharynx, oropharynx, and laryngopharynx, beta. Laryngopharynx. Nasopharynx, oropharynx, and laryngopharynx. Laryngopharynx is also called hypopharynx. Hypo means the lowest part. Laryngopharynx also called as hypopharynx. Hypopharynx. Now please understand. Jacket. Now everybody please see. Can you tell me what is the extent of pharynx? From what to what level? From skull base to C6 vertebra, beta. Skull base to C6 vertebra. Now everybody look at me, beta. Look at me. Now what is your skull base? What is your skull base? Just look at this, beta. Skull base is this level, beta. Where the hairline almost this level. And C6 is your neck, the end of the neck, beta. So between the skull base and C6 is your neck. Okay. Now I'm saying that the pharynx has got is a fibromuscular tube from skull base to C6 vertebra. From skull base to C6 is your neck, and that the neck has a column called pharynx. And now you're saying it has 3 parts: nasopharynx, oropharynx, laryngopharynx. How to decide it, beta? Look at see. What is in the front in the body? Nose. Behind the nose is which part? Nasopharynx. And nasopharynx has got what? Adenoids, beta. Adenoid are part of nasopharynx. Then nature put the which cavity? Oral cavity. Behind the oral cavity is which part? Oropharynx. Where you have what? Tonsils, beta. Yes, tonsils. Okay. Then come what? Larynx, beta. Larynx. Like larynx over here. This is larynx, beta. Okay. So larynx, behind the larynx is laryngopharynx. Larynx is laryngopharynx, beta. Now. Okay. Now please see. Just see. Now it's made better. Nose, nasopharynx. Oral cavity, oropharynx. Larynx, laryngopharynx. Okay. So nature has front put lot of things, but nasal cavity, oral cavity, larynx. Correspondingly, nasopharynx, oropharynx, laryngopharynx. Nasopharynx, what is the dominant thing over there? Adenoids in children. Oropharynx, what is dominant thing over there? Is tonsil, beta. When you see your tonsil, you're seeing the oropharynx, beta. Okay. And larynx behind that is laryngopharynx. That is a hidden area. I'll show you on that. Thank you. Now, okay. Now everybody, let us start the laryngopharynx, beta. Laryngopharynx has got other name also, hypopharynx, beta. Everybody, hypopharynx. Laryngopharynx is also called hypopharynx, beta. Hypopharynx. Am I clear? It has 3 parts. What are 3 parts of laryngopharynx? Number 1, piriform sinus right and left. पहले याद करेंगे, फिर समझ लेंगे फिर उसको, है ना? पहले just एक बार देख लेंगे पहले. Let us see it once, then let us understand it. Let's revise it, beta. All these words may be new to you, beta, है ना? It has 3 parts: piriform sinus right and left, beta. बोलो beta. Number 1, बोलो बच्चे. पहले get used to the words. Piriform sinus right and left. PS. Number 2, PCA. What is PCA? Post-cricoid area. Behind the cricoid, beta. What is cricoid, beta? Cricoid is a ring-like cartilage of larynx. Behind the larynx, behind the cricoid, what is the PCA? Post-cricoid area, beta. Okay. And third is posterior pharyngeal wall, beta. Posterior pharyngeal wall. Posterior pharyngeal wall, beta. Am I clear, beta? Posterior pharyngeal wall. Posterior pharyngeal wall. Okay. Now, in this picture, this is larynx. Everybody look at the screen, beta. This is larynx, beta. Larynx in the center, and this red thing is laryngopharynx, beta. Laryngopharynx. Everybody clear? Laryngopharynx. Now, I could never understand this whole thing. Piriform sinus. In my MBBS days, I could not understand what is piriform sinus and all that, where it is actually. Now, let us try to understand it. Now, imagine this, this remote is your larynx, beta. This remote is your larynx, beta. Okay. Imagine this remote is your larynx, beta. This remote. Can you see a remote over there? White remote, beta. Okay. Now, there is a balloon in my hand. The balloon filled with the air. The balloon is red in color, beta. Imagine the red color balloon. You know, Valentine balloon, beta. Valentine balloon. You know, red color balloon. Okay. Now, if I press this remote is what? Larynx. Balloon is what? Laryngopharynx. If I press this remote in the balloon, if you press the remote in the balloon, due to pressure of the remote, the balloon will be divided into three parts. Due to pressure of the remote, the balloon will be divided into three parts. One on this side of balloon, one on this side of the remote, one on this side of the remote, one behind the remote. Due to pressure of the remote, the balloon, the Valentine red color balloon, will be divided into three parts. Beta. How? One on this side of the remote, one on this side of the remote, one behind the remote. The part which went this side and this side of the remote is called piriform sinus right and piriform sinus left. The part which went behind it is called post-cricoid area. Why post-cricoid? Because it is behind the larynx. Beta. And you know, one cartilage of the larynx is cricoid. Post-cricoid area, behind the cricoid. Okay? And the sheath of the balloon. The sheath of the balloon is called posterior pharyngeal wall. The sheath of the balloon, mucosa of the balloon is called posterior pharyngeal wall. Posterior pharyngeal wall. Everybody, now get back to this picture again. I hope you can understand. This larynx is the remote, beta. Larynx has pressed the laryngopharynx. Can you see Valentine balloon, beta? Red balloon, which has been pressed by the larynx, beta. What is PS? Piriform sinus, right. What is other PS? Piriform sinus, left. What is PCA? Post-cricoid area. It's behind the larynx, beta. Post-cricoid means behind the cricoid. The cricoid is a part of larynx, beta. Post-cricoid area, and the sheath of the balloon is called posterior pharyngeal wall. Beta. This sheath is called posterior pharyngeal wall. And what lies behind is vertebra. Beta. Look at me, beta. What is your neck, beta? Larynx, laryngopharynx, and what is this, beta? Vertebra, beta. Which vertebra? Cervical vertebra. Look at your neck. Larynx, then laryngopharynx, and what is behind this is vertebra, beta. Okay, fine. Now, you will say, Rajiv, this is a line diagram. In the reality, where we see all these things, beta? In the reality, do we see all these things? Yes, we do see. Everybody look at screen, beta. If you remember this picture, beta. If you remember this picture, this photo. Okay. Now, let me try another way. Okay. Yeah, that's better. Now, please see. You remember yesterday, last time class, larynx. This is what a epiglottis is visible to you. Epiglottis is visible to you. Now, everybody, I hope remember epiglottis is anterior. Now, everybody, I hope remember arytenoid is posterior. Okay. Now, everyone, this is your larynx, beta. Okay. This is your larynx, beta. Okay. Epiglottis anterior, this is posterior, beta. Epiglottis anterior, this is posterior, beta. Okay. This is your larynx, beta. And this is the area where the laryngopharynx is there. It is lying collapsed. It only opens when food passes through it. Laryngopharynx is a channel for the food. Larynx is a channel for the air. Okay. When you eat biryani, biryani is passing from here. Okay, air is passing from here, beta. Okay, this is what, beta, supraglottis, hai na? Now something will open over here, beta. Everybody focus in this area. Something is going to open in this area, and that will be laryngopharynx, beta. Everybody focus in this area, beta, where my hand is. Everybody focus in this area, and you will see something magical happening there, beta. Please see, you know, can you see 1, 2, 3? So can you see larynx? This is laryngopharynx. Did you see something opened over there? Okay, once again, beta, larynx. This is laryngopharynx. Okay, larynx is there. Okay, now something going to open behind the larynx, on the side of larynx will be laryngopharynx, beta. Okay, 1, 2, 3. This is laryngopharynx, beta. Again, beta, larynx. Now something is going to open in front of you, beta. 1, 2, 3. Laryngopharynx. Very good, beta. Okay, can you understand, beta? Can you understand? Air passes from here. Food passes from here. There is a lumen there. You can't see that. There is a lumen there. Air passes from here. The food passes from here. This pariform sinus right, pariform sinus left, postcricoid area. This lumen. There is a lumen here, and this mucosa is called posterior pharyngeal wall. Larynx. This is laryngopharynx. The pressed balloon, beta. Pariform sinus right, pariform sinus left, postcricoid area, and posterior pharyngeal wall. All of these things end into esophagus, beta. Larynx end into trachea. The laryngopharynx end into esophagus, beta. Am I clear, beta? Larynx end into trachea. Larynx is the air channel. Larynx end into trachea. Laryngopharynx, food passes from here. When you eat biryani, some biryani passes from here, some biryani passes from here, some biryani passes from here, and all of these three channels end into esophagus, beta. Esophagus. You tell me, what is the extent of the pharynx? From skull base to C6 vertebra. C6 vertebra, beta, C6. At C6, pharynx ends, esophagus starts. So all these three things will end into esophagus, beta. Okay? Can you tell me larynx topic, beta? Anybody? What is the position of adult larynx? Remember, there is a table, pediatric larynx, adult larynx. Adult larynx position, bolo zara. Adult larynx position, bolo. Everybody put in the chat box. Adult larynx position is what? Try to C3 to C6. Adult larynx C3 to C6. So C6 is a very important vertebra, beta. At C6, larynx ends, trachea starts. At C6, pharynx ends, esophagus starts. C6, larynx ends, trachea start, because in our notes of larynx written that adult larynx is from C3 to C6. And we said today pharynx is from skull base to C6. So C6 is a transitioning vertebra where the larynx ends, trachea start. Where the pharynx ends, esophagus start. So the food is passing from here, here, and here. There are three options. Air passing from here only, central column. Okay? Am I clear, beta? Fine. Is it clear to all, everybody? Wonderful. So I hope everybody clear. Once again, beta, this is your larynx of. Today we are seeing what? 1, 2, the one which opening now. 1, 2, 3. Slow motion, slow. This is laryngopharynx. There is a lumen there, but you can only see when food is passing through it. There is a lumen definitely there, beta. Okay? Fine. Chalo. I hope you understood it, beta. Everybody write in the chat box, did you understand this or not? I need to know. Did you understand it or not, beta? Okay? Please write in the chat box, did you understand it or not, beta? Okay. Now, if I give you this question of visual question, beta. Now, would you be able to answer is, what are these two arrows indicating, beta? What are these two arrows indicating? Pariform sinus right and pariform sinus left, beta. PS, beta. Anukul Chauhan, you have asked that how do you differentiate the foreign body in the trachea and esophagus? The answer is that you have to go do two views, beta. In the anterior posterior view and the lateral view. The radiology people will be discussing that in detail also, the foreign body interpretation. But the answer to that question is you need two views, the anterior posterior view and the lateral view also, beta. Okay, but don't worry, radiology will be touching that. Okay, fine. Okay, very good. Wonderful. Great. Jui, thank you very much. Keep responding, guys. Keep responding. Be active in the chat box. That's good. Good. Be active in the chat box. It's good. It's good to know that. Very good. Okay, fine. Now, let's go further, beta. I hope you remember what are these two arrows indicating? Larynx. This is pariform sinus right. Pariform sinus left. This area is called postcricoid area and this mucosa is called the posterior pharyngeal wall. Anterior, posterior. Okay, fine. So these two arrows are indicating what? Pariform sinus. Will you be able to answer this question for your visual question, beta? What are these two arrows indicating in your diagram? Is the pariform sinus, beta. Pariform sinus, beta. Okay, chalo. Now, one more thing, beta. Now, let me show you, beta, pariform sinus from. What is normally there in pariform sinus is? What is there, beta? Can you tell me what is this arrow indicating? Everyone, can you tell what is this arrow indicating? One is this arrow, one is this arrow, beta. Pariform sinus. Is it clear? No confusion about this, beta. PS, beta. Okay. Now, what passes through this, beta, is food. And when you don't have food, what is there, beta? Saliva. So saliva in piriform sinus, beta. One here, beta. One here also, beta. So can you see saliva over there? Saliva means the digestive tract, na? Digestive tract contains saliva, na? So air tract, digestive tract. Okay. So this and this will end into esophagus, beta. If you see clearly, there's a little bit saliva here also, beta, in this area, post-cricoid area. Can you see this little bit saliva here also? The food has got 3 channels to pass. Piriform sinus right, piriform sinus left, this one, and there is area called post-cricoid area. All these 3 will end into esophagus, beta. Am I clear, beta? Fine. Now, everyone, now answer this question to me, beta. Now, what is this area, beta? The larynx, which area is in front of you right now? This is supraglottis. Okay. What is this? What is it, beta? Piriform sinus? Piriform sinus. I hope remember, supraglottis, the sensory nerve supply of supraglottis is by internal branch of superior laryngeal nerve. Try to recall larynx class. Supraglottis above the vocal cord. The sensory supply is by internal branch of superior laryngeal nerve, also called as internal laryngeal nerve. Okay. Now, please see, beta. Now there is a nerve here, beta. There is a nerve here, and that gives the branch to larynx. This is the same nerve gives the branch to the piriform sinus also. Same here, beta. This is the internal branch of SLN. It gives the sensory supply to the supraglottis. The same nerve gives a branch to the piriform sinus also, beta. Can you see, beta? Supraglottis and piriform sinus are neighbors. So they share the sensory nerve supply. From my larynx notes, I can recall that sensory nerve supply of supraglottis is by internal branch of superior laryngeal nerve, which is also called as the internal laryngeal nerve. And this nerve gives sensory supply to 2 areas. Number 1, yes, larynx topic, supraglottis, and number 2, piriform sinus. Because today I am clear that supraglottis and piriform sinus are 2 neighbors of each other, beta. Okay, am I clear, beta? Fine. Now, open your notes, beta. Open your notes, beta. Please see. Most common site of hypopharyngeal malignancy is piriform sinus, beta. One liner question. Most common site of hypopharyngeal malignancy is piriform sinus. Now, internal branch of SLN is equal to, write down is equal to, matlab, is same as, is equal to internal laryngeal nerve. It gives sensory supply to number 1, A, supraglottis, and number B, piriform sinus. Okay. So, sensory nerve supply of piriform sinus is same as sensory nerve supply of supraglottis, and both of these are neighbors, and they get the common nerve supply of sensory supply from the internal branch of superior laryngeal nerve, which is also called as internal laryngeal nerve. Beta. Internal laryngeal nerve. Now all of you see how the question is asked, beta. How this question can be asked. A PG level question. A patient presents an emergency with throat pain due to accidental swallowing of fish bone, beta. Any Bengali here, beta? If there is any Bengali, please write in the chat box. Any bong, brother? Any bong? Any bong here, beta? You know, you guys eat hilsa. There's a special fish available in Bengal. Hilsa, full of fish bones, beta. It's very tasty fish, but difficult to eat for a North Indian like me, because we are not trained to really, eat fish with too many bones in it. So if you eat some fish and the fish bone gets stuck and you have got a lot of throat pain, the surgeon removes the foreign body with the endoscope. But what happened is, surgeon removed the foreign body, but while removing foreign body, the surgeon accidentally injured internal laryngeal nerve. What is the key point? Internal laryngeal nerve, beta. Internal laryngeal nerve is other name of internal branch of superior laryngeal nerve. Where was the foreign body stuck? Where was the foreign body stuck? Base of tongue, tonsillar area, piriform sinus, or esophagus? Oh, piriform sinus. Piriform sinus. Why? Because I know piriform sinus sensory nerve supply come from internal branch of superior laryngeal nerve. Am I clear, beta? That's how it's called applied anatomy, the applied clinical anatomy, beta. This is what the future is, beta. The national exit test which they're proposing would be like looking like this, beta. And your exam also is already having the tilt or flavor of these questions now. You know it. So, but it is not that difficult. Let us trust our common sense. We are FMGs and we are proud to be FMGs, beta. This is what you should be within you. Yes, there is an exam which I'm finding challenging. But once I clear it, I'm as good as any other IMG or anyone like that. So trust your common sense, trust your acumen, and try to evaluate the question. Don't get scared by the body of the question, beta. Because sometimes you get so scared by looking at the length of the question, 4-liner, 5-liner, that you go, oh, no, I'm used to 1-liner, beta. Sensory nerve supply of pariform sinus is internal laryngeal nerve. But the same question asked in a story form. The surgeon removed the foreign body fishbone, and while removing the foreign body, he has damaged internal laryngeal nerve. Where was the foreign body stuck? Pariform sinus. This whole question is asking what? Not a very huge, difficult thing. It is only asking God, internal laryngeal nerve gives supply to which area out of these 4 areas? If you look at this question carefully, it's not asking you rocket science. It's only asking you a question in a story form. But the essence of question is, the internal laryngeal nerve supplies which area out of these 4 areas, beta. That's all. So let us change the outlook towards the exam. Let us not feel scared. I'm not saying every question will be easy question. 75, 80 question will be tough question. Very tough. You will just not be able to really sort of know anything about them. Let me honestly accept it. That's the way paper is. But still there are 200, 220 questions which will be at least partially known or known to you. Let us focus on them. And there are a lot of questions of simple category and little twisted category of this category. Even this we can handle better. If you ask yourself and write in the chat box, everybody, I want each one of you to answer in the chat box. Now please don't shy away from using chat box. That makes the things very difficult. How will I know that what you are feeling about the learning and understanding better? You tell me, is this question that difficult beta or it is doable? Write your feeling that applied anatomy question, clinical anatomy question. I'm not saying all of them, but majority of them are doable question beta. So write your feeling in the chat box so I know that are you able to get what I'm trying to convey to you. Okay, fine. Now, everyone, let me check the chat box with it. Is the video working? Somebody said video. Check your connection is in my. No, only. Is the video working, beta? Yeah, it's working. Yeah, it's working. Now, let's go further, beta. Laryngeal crepitus. What is laryngeal crepitus, beta? Everybody, laryngeal crepitus, beta. Laryngeal crepitus. Laryngeal crepitus. Laryngeal crepitus. Laryngeal crepitus, it's a clicking sensation felt when larynx is moved over cervical vertebra. It's a clicking sensation felt when larynx is moved over cervical vertebra, beta. Cervical vertebra. Clicking sensation felt when larynx is moved over cervical vertebra. Now, just stand over here. Now, just see everybody. This is your This is your larynx, beta. This is your larynx. Everybody try this with me. This is your larynx, and everybody hold your larynx and push it little behind and move it right, left. Don't move the neck. Neck nahi lana. Can you see, beta? Can you see? Everybody try this with me. Right now, where you are sitting in the room, hold your larynx and move right, left. Can you see that gritty sensation, beta? Can you see that gritty sensation which you are feeling as if your larynx is rubbing over the vertebra, beta? That gritty sensation, that clicking sensation, when larynx is moved over the vertebra is called laryngeal crepitus, beta. Can you see, beta? I'm doing like this, beta. Do like this. 1, 2, like this. I'm just pushing it behind and rubbing it over vertebra. This is called what? The laryngeal crepitus. Anybody, can you see? Prominence of larynx in male is called what? Adam's apple. Can you see beautiful Adam's apple, beta? This is the Adam's apple. Prominence of larynx in male is called Adam's apple, beta. Thank you, Lalji. Okay. Now, fine. Now, please see on the screen, beta. It is present in normal people. Write down. It is present in normal people. I hope all of you are normal people. We all are a little abnormal actually. But anatomically we are normal. It is present in normal people, beta. It is present in normal people, beta. Present in normal people. It is present in normal people, beta. Okay? It is present in normal people. Okay, now it is fine, beta. Okay, very good. normal people. It is absent in. It is absent in post-cricoid carcinoma. It is absent in post-cricoid carcinoma, beta. It is absent in post-cricoid carcinoma. This cancer called post-cricoid carcinoma, in this cancer, this crepitus is absent, beta. Okay. Now you say, Rajiv, how come this is absent? Look at screen, beta. Anybody? Look at this diagram, beta. What is this PCA, beta? Everybody speak out. What is the PCA? Post-cricoid area. Post-cricoid area. Imagine if you have got a big cancer in this area, beta. If you have got a big cancer in this area, look at this, beta. If you got a big cancer in this area, post-cricoid area, can your larynx touch the vertebra? If there is cancer in which area? What is this area? Post-cricoid area. Can you see the purple cancer over there? If the post-cricoid area has a cancer, how can the larynx touch the vertebra? Because there is a cancerous mass between the larynx and vertebra. So now you cannot rub the larynx over the vertebra. So that is why the laryngeal crepitus is absent in which carcinoma? Post-cricoid carcinoma. And this absence of laryngeal crepitus is a sign, beta. Look at your note, beta. This absence of laryngeal crepitus is a sign called Moore sign, beta. M-O-U-R-E. The absence of laryngeal crepitus is called Moore sign, beta. M-O-U-R-E. Absence of laryngeal crepitus is called Moore's sign, beta. M-O-U-R-E. Moore's sign, beta. Am I clear, bache? Fine. Very good. People are writing. The question was good and doable, beta. Very good. No Bengali here. There's not even a single Bengali here. I'm amazed, really. No bong here. That's not possible, yeah. Okay. Okay, fine. Now let us start the nasopharynx, beta. Nasopharynx. Behind the nose is nasopharynx. Yes. Behind the nose is nasopharynx, beta. Okay. To put it simply, the empty space behind the nose is nasopharynx, beta. Okay. It has two important landmarks. The nasopharynx has got two important landmarks. What are two important landmarks? Number one is eustachian tube. We'll call it ET. And number two, adenoid tissue, beta, which is more prominent in children, beta. Okay. I told you behind the nose is nasopharynx, where you have got the adenoids, which are more prominent in children. And one opening is eustachian tube opening. Now this is the look of the nasopharynx, beta. Everybody label it. Label it with the pen. This is the ET opening. This is adenoid. Adenoid, beta. Eustachian tube opening and adenoid, beta. Oh yes, I found one bong. Chiranjit Ganguly. Ganguly, yes. Thank you, Chiranjit. Okay, very good. Very nice. Check your connection, beta. It's going. I'm checking it from my, because I'm seeing that. Check your connection, beta. It's working well over here. I'm simultaneously checking on my mobile also that how the video speed is going on. Okay, everybody clear, beta? Everybody clear? There are two important landmarks. Can you tell me what are two important landmarks? The two important landmarks are, number one, eustachian tube opening, and number two is adenoid, beta. Okay, fine? Okay. Now, important concept, beta. Everybody focus on this area, beta. Now, everybody, can you tell me eustachian tube connects what and what? It connects middle ear with the nasopharynx, beta. What is the ME, beta? What is ME? Middle ear, beta. What is this, beta? ET. What is ET? Eustachian tube, beta. Eustachian tube connects middle ear with the nasopharynx, beta. Okay, bache, fine. Now, please understand, your middle ear is producing mucus continuously, beta. This pink is the mucus, beta. And that mucus comes via eustachian tube and goes to the pharynx, beta. Okay, let me draw with this other color, the green color, beta. This is the mucus, beta. Middle ear produces mucus and that mucus comes into your pharynx continuously, beta. Can you see, beta? This is a normal, natural design, beta. Middle ear is connected to nasopharynx via eustachian tube. Middle ear produces mucus continuously and this mucus is draining into the nasopharynx via this eustachian tube, beta. Now, can you understand, beta, if something blocks the eustachian tube, beta? For example, the adenoid became bigger in size, beta. The adenoid, this adenoid, na? became bigger in size and it blocks the eustachian tube. The adenoid or any other thing which blocks the eustachian tube opening. Now the mucus cannot come down into your throat or throat pharynx. Now this mucus will get collected in the middle ear, beta. The mucus will get collected in the middle ear and that mucus will become thick like a glue, beta. That mucus will become thick like a glue. This mucus will become thick like a glue, beta. There is a lot of mucus collection in the middle ear and that mucus will become thick like a glue and this disease is called glue ear, beta. Glue ear, G-L-U-E, glue ear, beta. Glue ear. Because you know what happens is the eustachian tube connects middle ear to nasopharynx. The middle ear produces mucus continuously and that mucus is drained via eustachian tube into your pharynx. But if some mass blocks the eustachian tube opening, the mucus cannot come down into the pharynx. Now, this mucus in the middle ear will become thick and or more thick and this becomes like a glue and that disease is called glue ear. And if your middle ear is full of glue, how can you hear properly? And then you'll be suffering from conductive hearing loss, beta. Okay, conductive hearing loss. Am I clear, beta? So middle ear full of glue and that will lead to conductive hearing loss. Everybody get back to your notes, beta. Now, same thing written over here, beta. Eustachian tube connects middle ear to nasopharynx. Therefore, nasopharyngeal diseases can lead to middle ear diseases, for example, glue ear also called as serous otitis media is equal to serous otitis media. Glue ear also called as serous otitis media which leads to CHL. What is CHL? Conductive hearing loss. But it's a very important concept as a doctor that the middle ear problems can be there if there is nasopharyngeal problem. Please understand these all concepts are important for your clinical practice also. You are not medical student, you are medical professionals of the future. So if a patient comes to your clinic with a nasopharyngeal disease, you must expect, there can be middle ear problem, hearing problem also in that patient. Because today I know as a doctor that eustachian tube connects middle ear to nasopharynx. Therefore, nasopharyngeal diseases can cause the middle ear diseases like glue ear. The glue ear is also called as serous otitis media, which leads to conductive hearing loss, we use the abbreviation CHL. Beta. Now, the next topic. Beta. The three topics in nasopharynx: adenoid, angiofibroma, and nasopharyngeal carcinoma. And if I put a star topic over here, I would not be wrong. But this is a star. This particularly angiofibroma, nasopharyngeal carcinoma. These are very, very important topics. Beta. Very important topics. Beta. Now let us discuss adenoid one by one. Beta. Number one, put a number one here. Beta. Number one, adenoid. Beta. Okay, make your notes as logical beta as possible. Okay, three topics. Number one, adenoid. Beta. Let us start adenoid. Adenoid is also called as nasopharyngeal tonsil. Adenoid, the other name is nasopharyngeal tonsil. You say, Rajiv, tonsil are in the throat, beta. Tonsil are here, throat is tonsil. No. Tonsil is a general word which means a lymphoid tissue deposit in the pharynx. I repeat, any lymphoid tissue deposit in the pharynx will be called tonsil. Even adenoid is a type of tonsil. The throat tonsils, which you call tonsil, are only a type of tonsil, beta. Okay, so adenoid is also a type of tonsil. It is called a nasopharyngeal tonsil because tonsil means a lymphoid tissue deposit in the pharynx. So adenoid is a collection of lymphoid tissue in the nasopharynx. Okay, fine. Well, first line clear, beta. Adenoid is what is the type of tissue it is? It is a lymphoid tissue in the pharynx. Okay, nasopharynx. It has no capsule, no crypts, no definite blood supply. It is a very ill-organized tissue. No capsule, no crypts, no definite blood supply. They are present at birth. What is adenoid, beta? Look at this picture, beta. Can you see, beta? This is your adenoid, beta. Just keep this picture in mind. Can you see this mass, beta, everybody? This is the adenoid, beta. This is the adenoid, beta. This A mane adenoid. This A is adenoid. Okay, beta? Fine. Are they there at birth? Yes, they are there at birth. So read your notes, beta. Adenoid is present at birth. Yes. They increase in size up to 6 years of age. They start decreasing in size at puberty and they disappear by 20 years of age. Once again, beta, see, adenoid is lymphoid tissue. Yes. It is very ill-defined tissue. Yes. It has no capsule, no crypts, no definite blood supply. Adenoid is there at birth. It increases in size in every child up to 6 years of age. It starts decreasing in size at puberty and it disappears by 20 years of age, beta. It disappears by 20 years of age. Everybody, it disappears by 20 years of age, beta. Now everybody, please see, look at the screen, beta. Everybody, now please see the two endoscopy picture, normal picture, beta. Number 1, number 2, beta. Number 1, number 2. Can you tell me which one is of child, which one is of adult, beta? In the chat box, please write down 1 child, 2 adult, or 1 adult, 2 child, beta. Please see 2 endoscopy picture. Let me go out of the picture, beta. You see, beta. Your question is, which one is child, beta? 1 is child or 2 is child, beta? Okay, which belongs to a child? Just write in the chat box write on 1 child or 2 child, beta. Okay, fine, everybody, fine. I hope you know. Oh, it is 2 is adult, beta. Why? In adults, we do not see any adenoid. In children, we see the adenoid, beta. Adenoid is there in children, yes, but they disappear by which age? 20 years of age. So this second endoscopy, this one is of an adult, because here I am not able to see any adenoid. They have disappeared. Anybody, what is this opening? You take into opening. It takes you to where, beta? It takes you to the, yes, middle ear. Very good, middle ear. Wonderful, wonderful. Okay, so 1 is of child, 2 is of the adult. Okay, I hope you're writing in the chat box. Okay, chalo. Now, next topic, beta. Same topic continues, but under that heading, adenoid hypertrophy, beta. Everybody, next topic is adenoid hypertrophy. Adenoid hypertrophy is a disease of school-age children. It is a disease of school-age children. First of all, adenoid is a normal tissue. Adenoid hypertrophy, too much enlargement, is a disease of school-age children. Okay, now it is more than physiological enlargement of adenoid. It is more than physiological enlargement of adenoid. I know adenoid increase in size in every child up to 6 years of age, but that is normal enlargement. Too much of enlargement is hypertrophy. It is more than physiological enlargement of adenoids, beta. Cause. Write down cause on the side, beta. Cause, beta. C-A-U-S-E. Cause. Put an arrow. Due to recurrent upper respiratory infection. I hope you remember, adenoid is what type of tissue? Lymphoid tissue. And you know, infection induces lymphoproliferation. Oh, okay. Lymphoproliferation means lymphoid tissue will get enlarged due to recurrent upper respiratory infection, beta. Okay, upper respiratory infection. The infection will induce lymphoproliferation, and adenoid is the lymphoid tissue. Recurrent infection. You know, some children get infection every now and then, every now and then, every now and then. So we would have, in them we will have this issue that adenoid hypertrophy is there. Everybody, again, you have a question to answer, beta. Simple question. I don't ask tough question. Now again, beta, you have got 2 things, beta. Number 1 and number 2, beta. 1 and 2. 1 and 2. Which is normal, beta? Which is normal, beta? 1 is normal or 2 is normal? Everybody look at screen, beta. You have got 1. This is 1. This is a 1 picture. And this is another picture, 2. Which is hypertrophy, beta? Can you tell me which one is 2? Is 1 normal or 2 is normal, beta? What is the 1? Normal. What is the 2? Adenoid hypertrophy. Very good. This is adenoid hypertrophy. Can you see, beta? Adenoid hypertrophy. This is normal, of course, beta. Normal. Normal, beta. This one is normal side, beta. This is adenoid hypertrophy side, beta. Can you see? The whole nose is blocked from behind, beta. The adenoid is so much enlarged over here that adenoid, there's no space, this end of the nose now. How can you breathe now? Here, at least you were able to breathe. You were able to breathe. Oh, this much air, the spaces go for the air to go inside your system. But here, if you see in this area, the whole adenoid are blocked over there. They are blocking the nose from behind. So that's why this child will always keep the mouth open. Can you see, beta? The child has to mouth breathe, beta. It's a mouth breathing child. So let me tell you one short question in your exam and short answer also. A mouth breathing child. Think of adenoid hypertrophy. There are clues, beta. There are clues. There's a YouTube channel of mine, Rajiv Dhawan ENT. I put, couple of things over there. Like I put 6-minute video and 10 clinical scenarios of ENT. Just here, that was 6 minutes after the end of the class, not now, when the whole class finishes of ENT. If you hear those 10 clinical scenarios, 6 minutes, you'll revise a lot of things which can be asked in a clinical story, but they are easy to crack. But once you know them, they're easy to crack. But over there, okay. In that same channel, you have got some videos like 70 important questions of ENT beta, and there is a 3-hour video. It's like a Netflix kind of thing, and 3 hour means that you will have total discussion of those 70 questions to revise the ENT in the question format actually. Okay, there's another video of 1 hour bit over there, which is to be done in the month of end of May. End of May, you do this 1 hour video, and that is rapid review of ENT. Rapid review of ENT in 1 hour. In 1 hour, we do, in the end of the May, we'll do those videos. This all are available on the channel. It's my YouTube channel, ENT Rajiv Dhawan. If you write Rajiv Dhawan ENT, RAJIV, Rajiv Dhawan ENT, you find all these videos there. But don't watch too many videos, better. Don't waste too much time. Only 3 videos are of your use, better, over there. There's so need PG videos and there. One is the 70 question video. Other is rapid review of ENT in 1 hour. And third is this, 10 clinical scenarios. I'll keep posting a link on the Telegram channel. I think a lot of people have joined Telegram over there. So I'll keep posting at the right time to revise what actually. Not now. That 1 hour rapid review is for the last week of May. This 6 minutes is for any time you can use it. But anytime you're sitting in the toilet, you're not doing anything, you just put this for 6 minutes and you just see that video, and that will revise you 10 minutes better. Let us not waste too much of time in the social media stuff and all that. Let us keep an exact time every day. Okay, post lunch I can use Telegram, etc., or YouTube, some last session videos, last review question, 4 session questions of the FMGE. But that's 1 hour after dinner. I can do that. But don't keep on doing all these things throughout the day. It disrupts your usual study. It disrupts your notes revision. It disrupts your usual questions what you do. Let's fix that 1 hour. Post dinner 1 hour. You might keep it for the social media activity, but keep them limited only for academic purposes, beta. Only productive activities, beta. Only productive activity, no reproductive activities, beta. Sorry for that. Only productive activities, no reproductive activities. Everything is suspended till 4th of June, but 4th of June evening become what we are actually. Okay? That's what we are proud to be imperfect. So this child is a mouth breathing child, beta. Okay? Now, let's see the next part of your note, beta. The child is a mouth breathing child. This is the biggest clue in the question is this one, beta. Okay. Now, child has got an adenoid face, beta. Let us write adenoid face, 4 features, beta. Number one is open mouth. Yes, I know now. Look at the picture in your notes also. Open mouth. Pinch nose, because the child is not breathing from nose, beta. The mouth is being used to breathe. But open mouth, pinch nose, high palate. Due to mouth breathing, the palate goes up. High palate. Number 1, number 2, number 3, and number 4, beta, malocclusion of teeth. There are 4 features of adenoid face, beta. Adenoid face is a typical look of the baby called adenoid face with the mouth breathing baby. And the 4, speak with me, what are the 4 features of adenoid face? Number 1, open mouth, because mouth is used for breathing. Nose is useless now. Pinch nose, due to mouth breathing, the palate goes high. If the palate, look at me, beta, if the palate goes high, the upper teeth will also go high, beta, because upper teeth are attached to palate only. If palate goes high, upper teeth go high, upper and lower teeth cannot touch each other, and how you see, your upper and lower teeth touch each other, but in this child, howsoever he may try or she may try, there will be some gap left between the 2 teeth. But upper and lower teeth cannot touch each other now, and this is called malocclusion of teeth. Why it is happening? Because palate goes up. Okay, fine. Now this is your adenoid face. Adenoid face. Number 2, oh, rhinolalia clausa. Always we will have active revision. Oh, remember, rhinolalia clausa. Clausa means close. Close means nose is closed. Yes, adenoid has closed the nose from behind. I just saw that picture. Adenoid is closing the nose. Rhinolalia clausa. Anybody? Is it hypernasality or hyponasality? Anybody? Can you write in the chat box, beta? Is it hypernasality or hyponasality? I'm waiting for you in the chat box, everyone. Please write in the chat box. Rhinolalia clausa is hypernasality or hyponasality, beta? Very good, beta. Very good. Everybody, you're responding. I'm so glad. Other people also, please do respond in the chat box. It makes the class interactive for you and for me also, beta. Is it hypernasality or hyponasality? Hypo or hyper? When nose is blocked, is it hyper or hypo? Nose is blocked, the clausa one close. Hyper or hypo, beta? Hyper or hypo, beta? Everybody. Raghuvinder Singh, Keshav, think again, beta, think again. Rhinolalia clausa, nose is closed, nose is closed. Nose closed will be hyponasality or hypernasality. Everybody, can you try it, beta? Again, go back to your larynx note and see over there. Yes, Pratibha, correct, beta. It's hyponasality. Everybody, please see your note. Adenoid is a cause of hyponasality, beta, not hyper, hypo, hyponasality. Everybody, you are allowed to commit mistakes, beta. Don't shy what other people will think. Even if you answer the question wrong, I'll be very happy at least you responded, beta. That's not a problem. I'm not here to assess you. I'm here to assist you. Even if you do something wrong, if I ask you, I told you. If I ask you, what is this bone? You said, sir, tibia. I don't have any problem. I don't have any problem. If you call this tibia, I'm glad that you're trying to learn. I tell, no, bache, this is hired bone. And next time you know it's hired bone, then you revise and you know it's hired bone, beta. So don't shy away from committing mistakes, but try to recall, oh, adenoid closes nose, closing noble rhinolalia clausa, and clausa is hyponasality, beta. Everybody clear, beta? Everybody clear? Wonderful, beta. Yes, that's the way I want the chat box to keep booming, beta. That's what, wonderful. Plus minus glue ear, beta. Glue ear will lead to what is CHL, beta. CHL is what, beta? Conductive hearing loss, okay? It is in the bracket mostly bilateral. Mostly bilateral, beta. Why? This is your adenoid. This is your adenoid. This is your eustachian tube opening, eustachian tube opening. Right? The center adenoid, eustachian tube, beta. When adenoid hypertrophy happens, beta, when adenoid hypertrophy happens, then it is going to cause the blockage of both eustachian tube, beta. Both. Can you think of it? Adenoid hypertrophy is going to cause the blockage of both eustachian tube, beta. Because adenoid is in midline, it is going to cause the blockage of right side and left side also, beta. So I would always think that adenoid baby can have glue ear, beta. This is one thing you should keep in mind. Adenoid baby can have glue ear. It's a age-old MCI question. They make a story of adenoid and they combine that story with glue ear, beta. I know, oh, adenoid baby can have glue ear. Because adenoid is a nasopharyngeal problem and glue ear is a middle ear problem. But I do understand middle ear is connected to nasopharynx via eustachian tube. But adenoid is going to cause the blockage of eustachian tube. And that's why in adenoid, I will have glue ear also in the picture. And that is mostly bilateral. And glue ear also called as serous otitis media. And that causes conductive hearing loss. Do not worry. We'll be discussing glue ear as a complete topic in the ear topic tomorrow. Okay? Fine. Chalo. What is the name of surgery, beta? The treatment is surgery. The surgery is called adenoidectomy. Very good. The surgery is called adenoidectomy. The surgery is called adenoidectomy. Palpate adenoid before removal because you cannot see your adenoid, beta. Adenoid is right behind your nose, so check it once. Now, position of patient during surgery, beta. Right now, position of patient during surgery. Position of patient during surgery is called Rose position. Spelling beta R-O-S-E. Underline beta Rose position. What is the name of the surgery? Adenoidectomy. What is the name of position? Rose position. Can you see Rose position, beta? Look at the picture. The neck is extended, beta. Like Rose position, neck extension. Can you see neck? This is a Rose position, beta. There is a shoulder bag. There is a neck ring, beta. There is a ring of the head, beta. You put a shoulder bag and you extend the neck. And this position is called a Rose position. The same position is used for tonsillectomy, beta. The same position is used for tonsillectomy, beta. But be careful. Be careful. Over neck extension. If look at me, beta. Look at me. Neck extension. But neck extension, beta. Neck extension. But if you extend the neck too much, it's a child, beta. Adenoid is a child. Tonsil is generally a child. If you extend the neck too much, there may be cervical vertebral dislocation or subluxation. Overextension of neck can lead to atlantoaxial subluxation or C1, C2 subluxation, very serious complication, and this is called Grisel syndrome. 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 Overextension of neck will lead to atlantoaxial subluxation, and this is called Grisel syndrome. What is the method of surgery? Curettage. Curettage. We curate it out. Look at my hand. You remember curates? Curate, blind curate. Curettage, like this curettage. Name of instrument is St. Clair Thompson adenoid curate. Name of instrument, read it, beta. The name of the curate is St. Clair Thompson adenoid curate, beta. Name of the instrument is St. Clair Thompson adenoid curate, beta. Okay, can you see, beta, this curate, beta? Your instrument, beta. St. Clair Thompson curate is used for which surgery? Adenoidectomy. Once again, beta, what is the name of surgery? Adenoidectomy. What is the name of position? Rose position. Okay, rose position, beta. Okay, what is the rose position? Neck extension. Okay, overextension can lead to what? Which vertebral subluxation? C1, C2 or atlantoaxial subluxation, which is also called a bolo, beta, which is also called as bolo, which speak it, which is also called as Grisel syndrome, beta. What is the method of surgery? Curettage. What is the name of instrument? Look at screen, beta. Name of instrument is St. Clair Thompson curate, beta. Okay, bache? Fine? Chala. St. Clair Thompson curate. Am I clear, beta? Fine. Now, Rajiv, let me try to show you if it works. At least you have some idea. Can you see, beta? This is the patient under anesthesia. Patient under anesthesia. Can you see that? Patient under anesthesia. This is a patient under anesthesia. What is the position? This is a baby's mouth, beta. What is the position of the patient? Neck extension. What is the name of surgery? Adenoidectomy. What is the name of the method? Curettage. How we do the curate? Like this. Scoop it out blindly. What is the name of instrument? St. Clair Thompson curate. St. Clair Thompson adenoid curate. St. Clair Thompson adenoid curate. Now look at this, beta. Can you see, beta? He's just curating that out like this, beta. Curettage, beta. Curating out. Can you see that? Curettage. Oh, curettage, beta. Okay. Fine, beta. Now this is your, like this you do, and you just curate it out, beta. Scoop it out. Oh, curettage. Am I clear, beta? Fine. Very nice, very nice. Okay. Is it interesting? Tell me, are you enjoying the process of learning or no? Tell me in the chat box, beta. Okay. One second, somebody asked a question. Sir, any Ananya, we do X-ray, beta. For adenoid, we do X-ray. Any investigation, we just do X-ray and that's okay. That's why we palpate the adenoid before removal. Before removal, we check it, but yes, we get the X-ray done, bache. Everybody clear? It's hyponasality, beta. Okay, no problem, beta. Don't even think that if you wrote hypernasality, oh, I did a mistake. No problem. You are more than welcome to do mistakes with me. I'm not judging you. I'm not evaluating you. I don't give a damn about what you are really, thinking that, what you are really doing the mistakes. I don't have any problem in that bit. I want you to do the mistakes now so that on the exam day, you already know, oh, this is a common mistake we do. On the exam day, I have done this mistake earlier. This time I will not do it. So with faculties, you need not really worry, beta. We are just one of you guys only. We have done, at least I have done so many mistakes in my life that I am okay with it. Honestly, I keep improving, I keep challenging myself, I keep fighting within myself that I have to really evolve further and further. But I've done so many mistakes in my own life that I don't really have any issue with anyone who's doing mistakes because I am the last person to be judgmental about anyone. I think I'm okay with that. It's okay. Everybody has a process of learning. Everybody has got a graph of learning. Everybody has a, sort of, some points, some people learn better, some point other people learn better. But let us do the mistakes now. It's okay. Perfect, brother. So do not shy away from answering any question, brother. Right, bindas, brother. Koi baat nahi. Let us discuss angiofibroma. Very favorite topic, angiofibroma. Very, very important topic, angiofibroma. Also called as, now the new name, please do remember, the new name is juvenile nasopharyngeal angiofibroma. JNA, beta. Juvenile, it happens in the younger boys, beta. Juvenile nasopharyngeal angiofibroma is same as angiofibroma, beta. JNA, juvenile, because it is seen in children, young boys, beta. Juvenile nasopharyngeal angiofibroma. Very nice. Can we start it, beta? Look at the name, beta. First of all, we are doing nasopharynx and put number 2. This is number 2, beta. Number 2 is second topic. The nasopharynx has 3 topics: adenoid, angiofibroma, nasopharyngeal carcinoma. The second topic is angiofibroma. Now let's do this topic, beta. Now angiofibroma, first of all, it's the most common benign tumor of nasopharynx, beta. It's a tumor of nasopharynx, not of nasopharynx. So this is number 2, my dear friends. It is the most common benign tumor of nasopharynx. Very good. Site of origin is sphenopalatine foramen. Everybody revise with me. Site of origin is sphenopalatine foramen. It's a benign tumor of nasopharynx. It is the most common benign tumor of nasopharynx. Oma means tumor, benign tumor. Is it a tumor of nose or is it a tumor of nasopharynx? No, it's a tumor of nasopharynx. It is the most common benign tumor of nasopharynx. The site of origin is sphenopalatine foramen. It's a highly vascular tumor. Look at the name, beta. Angiofibroma. Look at the name, beta. Angio means blood vessels. Blood vessel, beta. And look at it is not supplied by blood vessel only. It is made of blood vessels. It's a highly, look at the name, angiofibroma. So it is made of blood vessels, beta. Angio means blood vessel. It is highly vascular tumor. It is seen in adolescent boys, beta. Very, very important clue in the question is always adolescent boy. Boys. 12 to 14 year, beta. To the 12 to 14 year boy, question in ENT is angiofibroma, beta. You want to confuse yourself? You can. But you know what? There are certain things which do not have any challenge in the 12 to 14-year-old boy. Okay? Think of angiofibroma. The tumor can extend into nose, cheek, orbit, and brain. Nose, cheek, orbit, and brain, beta. Nose, cheek, orbit, and brain. The tumor extends into nose, cheek, orbit, and brain, beta. It's a benign tumor. It can go to nose, cheek, orbit, and brain, beta. Anybody? Orbit. What will happen, beta? Orbit. Proptosis. Anybody? What is proptosis, beta? What is proptosis? Anybody? What is proptosis, beta? Can you see, beta? The eye comes out. Proptosis. Can you see the eye is protruding out? And this is called, fill in the blank, beta. This is called frog face deformity. This is called frog face deformity. This is called frog face deformity, beta. Frog face deformity. Frog face deformity. This is called frog face deformity, beta. Everybody fill in the blank, beta. This is called frog face deformity. Everybody write over here. This is called which deformity? Frog face deformity. Because eye comes out, which is called proptosis, and that is called frog face deformity. Frog face deformity. Called frog face deformity. Frog face deformity. Frog face deformity. That's going to be better. Frog face deformity. Okay. Clearing the picture. Now this is the star question of MCI, many times asked, beta. 12 to 14-year-old boy with nasal mass, because tumor come in the nose, with perfuse epistaxis. Epistaxis, beta. Let me tell you a short question of MCI and how to crack it. Young boy with nasal bleeding is angiofibroma. Young boy with nasal bleeding is angiofibroma. What is epistaxis? Nasal bleeding, na? So whenever you get any question in NEET PG, INICT, AIMS paper, MCI paper, USMLE, anywhere, beta, anywhere, young boy, why are you saying boy? Young boy with epistaxis is 100% angiofibroma question, beta. Don't even really dissect the question too much. Do not go for rare answers. Do not dissect the question too much. Do not change the choices again and again in your paper. And you know from your past experience, if you've given the paper earlier, whenever you change the answers too many times, the answer goes wrong, beta. Let us go with the common sense, with the common answers. Beta. Common sense, common answer is the right approach for MCI. Beta. It's a screening exam. Beta. They want you to know the commoner things more. Now, investigation. Would you biopsies? Not at all. Biopsies contraindicated is MCQ. Beta. Never biopsy angiofibroma. Biopsy is contraindicated. Okay. Now, CCT. What is CE? Anybody? What is CE? Contrast enhanced CT. Beta. You know, contrast, whenever you have to do vascular studies, it's a vascular tumor. For vascular tumors, you give contrast. Beta. Contrast enhanced CT scan shows what? A particular sign called, speak up beta with me. Everybody speak the name or the sign. Hallman, Miller sign or antral sign. Beta. Hallman, Miller sign or antral sign. Everybody speak with me. What is the name of the CT scan sign or CCT sign in this patient is Hallman, Miller sign or antral sign. Radiology question, they'll describe the radiology, but let me tell what it is. It is anterior bowing or posterior wall of maxilla. Actually, antra means maxilla, beta. That's why antral sign. Anterior bowing or posterior wall of maxilla is called Hallman-Miller sign or antral sign. This tumor pushes the maxilla forward, beta. This tumor pushes the, look at me, beta. What is maxilla? All of you touch your maxilla. This is your maxilla in the cheek, beta. This tumor is pushing the maxilla forward, beta. Forward. Maxilla forward, beta. Come here. Now, please understand, this is a radiology thing, but I can explain it to you if you want to understand. Now, please see, I am the angiofibroma. Aham brahmasmi. You know aham brahmasmi? I am the angiofibroma, beta. I am standing in the nasopharynx. Okay? The tumor belongs to nasopharynx. If I come forward, I go to the nose, beta. In front of nasopharynx, if the tumor can extend to number one, nose, beta. Then it has to go to the cheek, beta. Okay? Look at me, beta. This is your nose. This is your cheek, beta. This cheek is here. Anybody, or can if you tell me which bone is between the nose and the cheek? Which is this bone, beta? Maxilla. Maxilla. All of you touch your nose, then you touch your cheek. Which bone is between the two is maxilla. Okay. Now my friend represents maxilla. Lalji represent maxilla, beta. Okay. Now I am standing in the nasopharynx over here. I am the angiofibroma. This is cheek, beta. This is cheek. Everybody, this is cheek. Okay. Now this area is cheek, beta. Lalji, this my friend of mine represents maxilla, beta. I am standing in nasopharynx. I am the angiofibroma. If I grow forward, I grow into the nose, beta. Now I have to grow here, beta. What is this area, beta? Cheek. What is between nose and cheek is the bone called maxilla. Okay. Now Lalji, my friend represents maxilla. I have to cross behind the I have to grow over here, beta. I have to grow behind the maxilla. First of all, I have to grow in this area behind the maxilla. Then only I can grow into the cheek, beta. Okay, you understand? From nasopharynx, if I have to grow into the cheek, this friend represents maxilla. I have to grow first of all behind the maxilla over here. I keep growing for months and months and months over here. And then one day I come out of this area and reach over here. And then I reach the cheek, beta. That's why I say the tumor goes to the nose, to the cheek, beta. Now when I'm growing over here, look at it from the side, beta. He's maxilla, I'm the tumor. Okay, I'm growing over here for last 2-3 months. What I will do, look at this black line. This black line represents the posterior wall of maxilla. Posterior wall of maxilla, this line, okay? Now what I will do, I will be growing over here. I will push the posterior wall of maxilla forward, like this. I'll push the posterior wall of maxilla forward and this sign can be seen on CT scan and this is called antral sign or Hallman-Miller sign. What is it, beta? It is anterior bowing of posterior wall of maxilla. Matlab, the tumor is pushing the posterior wall of maxilla forward like this, beta. And that is called Hallman-Miller sign or antral sign. Thank you, Lalji. Okay. Now, everybody look at screen, beta. You might say, Rajiv, can we see that on CT scan? They will teach you in radiology. But let us challenge ourselves over here, beta. Everybody, look at screen, beta. Okay, I leave it with this. This is CT scan. Very high level, AIMS level question. Now, please see, this is the cut of CT. You know, CT is cut. This is an axial cut like that. Axial cut like this kind of cut. Okay. Now, see, this is the normal side, beta. This is the normal side, beta. Normal side. Now, this is which bone, beta? This is maxilla, beta. You know maxilla contains maxillary sinus? This black thing is maxillary sinus, beta, maxilla. Okay. Can you see, this is disease side, beta. D1 is disease side. Can you see, this is the posterior wall of maxilla here, beta, normal side. But can you see posterior wall of maxilla here, beta? This is the tumor. Okay, tumor. Tumor has pushed the posterior wall of maxilla forward, beta. Normal side, posterior wall is here. This is the maxilla containing maxillary sinus, and this is a normal side. This is the posterior wall of maxilla. But here, this is tumor, beta, and the red arrow is showing the tumor is pushing the posterior wall of maxilla forward, and that is called Hallman-Miller sign or antral sign, beta. Okay, once again, beta, Hallman-Miller sign or antral sign is a CT scan sign of angiofibroma. It means that anterior bowing or anterior pushing of the posterior wall of maxilla forward, beta. Okay, anterior bowing of posterior wall of maxilla forward as compared to normal side. This is posterior wall of maxilla, and here this is posterior wall of maxilla. There is a difference in that posterior wall of maxilla, and this is called Hallman-Miller sign or antral sign, beta. Am I clear, beta? Fine. Now, number 3 is angiography, beta. Of course, a vascular tumor, you would need angiography also. Angiography will be required. Then angiography will be required, beta. Angiography. And treatment is surgery, beta. Treatment is surgery. Okay, fine. This was the angiofibroma. Angiofibroma. Okay, so angiofibroma is the most common benign tumor of nasopharynx. Points to remember. It is a highly vascular tumor. It is seen in adolescent boys. It can extend to nose, cheek, orbit and brain. The orbit part will cause proptosis, and that will lead to a typical deformity called frog face deformity. The typical MCQ will be 12 to 14-year-old boy with a nasal mass and profuse epistaxis. I know young boy with epistaxis is 100% angiofibroma. Young boy, epistaxis is 100% angiofibroma. Angiofibroma is also called as juvenile nasopharyngeal angiofibroma. Juvenile, why? It's seen in adolescent boys. Nasopharyngeal, why? It's the most common benign tumor of nasopharynx. And biopsy is contraindicated. It's a highly vascular tumor, and the CT scan or CCT would show Hallman-Miller sign or antral sign. You also do the angiography, and the treatment is surgery. Okay. Now let us start the third topic. Is nasopharyngeal carcinoma. Third topic is NPC, nasopharyngeal carcinoma. NPC, we call it NPC, nasopharyngeal carcinoma. Okay. Right. See where there. See your notes, number 3, third topic of nasopharynx. So write down number 3, bache. Number 3, we said that there are 3 topics in nasopharynx. One is adenoid, angiofibroma, benign tumor. Now comes the cancer, beta. Nasopharyngeal carcinoma is more common in China. Etiology. This cancer is more common in China. अगर China है, तो etiology कोई virus ही होगा. If it is China, the etiology will be some virus only, na? Which virus? EB virus. Very good. EB virus. Epstein-Barr virus. Where you see this red color box means MCQ already come or can come in future, beta. This red box I put very selectively at couple of places, beta. This question has come or can come in the exam, beta. Okay. Now, site of origin is fossa of Rosenmuller. Fossa of Rosenmuller. Site of origin is fossa of Rosenmuller. Try to recall, beta. Angiofibroma, the site of origin was sphenopalatine foramen. Look above, beta. Look above your notes, beta. Look at angiofibroma. Look at everyone. Angiofibroma, please see. Site of origin is sphenopalatine foramen. Sphenopalatine, site of origin of angiofibroma is sphenopalatine foramen. But site of origin of nasopharyngeal carcinoma is fossa of Rosenmuller, beta. Okay, bache. Now, where is this fossa? Look at this, beta. This is the fossa, beta. Can you see? What is this opening, beta? Anybody? What is this opening? Anybody? What is this opening, beta? Eustachian tube opening. Can you see a yellow arrow there? This is fossa of Rosenmuller, beta. Okay, label it, beta. This is FOR. What is FOR? Fossa of Rosenmuller. FOR. Everybody label it. Fossa of Rosenmuller, beta. Fossa of Rosenmuller. FOR. What is FOR? Fossa of Rosenmuller. It lies just above Eustachian tube opening. Now, everybody get ready to apply your clinical orientation now. Everybody. Now, please see. Now, a cancer is starting from this area, beta. The cancer is starting from this area. And it blocks the Eustachian tube opening. Now, if a mass blocks the Eustachian tube opening, what will happen in the middle ear? Which disease? Bolo beta, which disease? If something blocks the Eustachian tube opening, which disease will happen in the middle ear? Glue ear. Glue ear is also called as serous otitis media. And glue ear will be causing what type of loss? Conductive hearing loss, beta. You know? So this patient will be having conductive hearing loss also. So nasopharyngeal problem can cause middle ear problems like glue ear, which called CHL. What is CHL? Conductive hearing loss, beta. Okay, beta, fine. Now, will it happen on both side or one side? One side cancer is mostly unilateral. Adenoid is bilateral. Adenoid will cause glue ear both side. But nasopharyngeal carcinoma will cause glue ear only on the one side, beta. Okay. Now look at screen, beta. This fossa lies just above ET. Opening, beta. Write down opening. This fossa just lies just above ET opening, beta. ET opening. This fossa just lies above ET opening. It will cause unilateral ET blockage. That will cause unilateral glue ear. Oh, my concept. Nasopharyngeal problem cause the middle ear problem like glue ear, also called as serous otitis media. And that will lead to conductive hearing loss, beta. CHL. CHL, again unilateral. Highlight the word unilateral. It will be one-sided, beta. Okay? Unilateral, beta. Okay. Unilateral. Unilateral conductive hearing loss due to unilateral glue ear, beta. Okay, bache, fine. Now, right on the side, beta. NPC is a hidden cancer. NPC is a hidden cancer, beta. Hidden cancer means occult primary. It's written in your notes also, but I want you to highlight this point, beta. NPC is a hidden cancer. Hidden means occult. Occult means hidden. Primary means cancer. Occult primary, hidden cancer. Why? Can you see behind your nose, beta? You tell me. Every day you see behind your nose, beta. Have you ever seen behind your nose, beta? Do you know what lies behind your nose? No. But do you see your tongue every morning? Yes. If you got a minor ulcer on your tongue, look at me now. If you have got an ulcer on your tongue, here, the ulcer on the tongue, every morning you will, when brushing, it's paining. You will see in the mirror, why there is ulcer. At least you will show the doctor faster. Okay? But behind the nose, कुछ चल रहा है, किसी को क्या पता क्या चल रहा है? नाक के पीछे क्या चल रहा है? कोई दुनिया में कोई नहीं जानता. Nobody knows what goes behind the nose. It's a hidden cancer. So what happens is, the most common clinical presentation or manifestation of nasopharyngeal carcinoma, very, very important question. Most common manifestation of nasopharyngeal carcinoma is, write down, is metastatic cervical lymphadenopathy. Or secondary neck node. Most common manifestation of nasopharyngeal carcinoma is a metastatic cervical lymphadenopathy or secondary neck node. Secondary neck node. Metastatic means secondary, cervical means neck, lymphadenopathy means node. Secondary neck node is a layman term. The technical word is metastatic cervical lymphadenopathy. Guys, please understand, when primary is hidden, the manifestation is secondary neck node, beta. When primary is hidden, the manifestation is secondary neck node, beta. So what is actually happening? What I'm trying to say, this patient does not know he has a cancer. Then one fine day, he notices that he has got neck nodes like this, beta. Can you see, beta, neck nodes, beta? Neck nodes. Why? Because what happened was, the cancer was behind the nose going on here, beta. Nobody knew that. It's an occult primary behind the nose, but it already metastasized to the neck node, and poor chap does not know that he's suffering from cancer. He comes to the clinic and he said, "Doctor, I've got a neck swelling." And then retrospectively, when I put my endoscope in the nose, I find, oh my goodness, there's a cancer there. That's a very scary part of the story. That's why the commonest question asked in MCI of nasopharyngeal carcinoma is this one, beta. Most common presentation or manifestation or of clinical manifestation of nasopharyngeal carcinoma. Most common clinical manifestation of nasopharyngeal carcinoma is metastatic cervical lymphadenopathy or secondary neck node, because this is a hidden cancer behind the nose. Nobody knows it, beta. Now, NPC can cause cranial nerve palsy also, beta. NPC can cause cranial nerve palsy also, beta. Next one. This tumor can cause paralysis of all cranial nerve. Beta. Write down all except 7th and 8th. Beta. All nerves except 7th and 8th. This tumor can cause paralysis of all cranial nerves except 7th and 8th. 7th and 8th. Beta. Okay, bache, 7th and 8th. And this leads to why cranial? Look at me, beta. What lies above the nasopharynx? Brain. Look at me, beta. What lies above? This is nasopharynx. Huh? What is the pharynx upper limit? Skull base to C6 vertebra. Skull base, beta. Skull base has got foramina of cranial nerves, beta. So tumor, look at me, beta. I am nasopharynx. If I go up, it's brain, beta. Okay, I can eat away the cranial nerve. So it can cause paralysis of all cranial nerves because nasopharynx roof is brain, beta. Okay, so it shows a triad called Trotter's triad. This is a very important question, beta. Trotter's triad of NPC, beta. And what is NPC? Nasopharyngeal carcinoma. And the good thing is the mnemonic is also NPC. Write down NPC, beta. The mnemonic is also NPC. Trotter's triad is seen in NPC. What is NPC? Nasopharyngeal carcinoma. What is NPC? Triad. The triad mnemonic is also NPC, beta. N mane neuralgia of temporoparietal area. Of temporoparietal area due to 5th nerve involvement. Palatal palsy due to 10th nerve involvement. Vagus. And conductive hearing loss, beta. All unilateral, beta. All are unilateral feature, beta. All unilateral feature. Once again, beta. Trotter's triad of nasopharyngeal carcinoma, NPC, has a mnemonic of NPC. What is N? N means neuralgia in temporoparietal area. Due to which nerve involvement? Trigeminal nerve involvement. Why nerve involvement? I told us nasopharyngeal carcinoma can cause paralysis of cranial nerves, beta. So 5th nerve involvement causes neuralgia in temporoparietal area. And P mane palatal palsy due to 10th nerve involvement, vagus involvement, and C mane conductive hearing loss. And all of these features are unilateral. Now treatment is chemoradiation is a better answer than radiotherapy, beta. Okay, so please, there are 2 MCQs possible. Whenever this symbol comes, beta, whenever this symbol comes, this symbol means that if this is not given the choice, please mark radiotherapy. Okay, don't think of surgery, don't think of chemotherapy. Either they will give best answer, chemoradiation, or the second best answer is radiotherapy, beta. Radiotherapy. Am I clear, beta? Okay, fine. This is nasopharyngeal carcinoma, beta. NPC, beta. Guys, let us see which virus is causing nasopharyngeal carcinoma. Epstein-Barr virus, beta. Okay, site of origin is fossa of Rosenmuller, beta. And you know, it causes unilateral conductive hearing loss due to glue ear. Now, I know it's a hidden cancer. That is why the presentation most common is metastatic cervical lymphadenopathy or secondary neck node is a very important question. Then Trotter's triad, beta. Let us revise Trotter's triad. NPC, neuralgia of temporoparietal area, P mane palatal palsy, C mane conductive hearing loss, and chemoradiation is the best treatment, and second best answer of the question is radiotherapy, beta. Let us start the oropharynx now. Or everybody, let us start the oral. Pharynx has got 3 parts: laryngopharynx, nasopharynx. Let's start oropharynx, beta. Oropharynx, it has following parts. First of all, where is the oropharynx, beta? Now let me show you the oropharynx, beta. What is the concept of oropharynx, beta? Everybody look at screen, beta. What is the concept of oropharynx, beta? Please see. This is oral cavity, beta. You know, teeth are part of oral cavity. Okay. Hard palate, oral cavity. Anterior 2/3 of tongue, oral cavity. Up to teeth is oral cavity, beta. Above, down, middle, whatever is there. Up to upper teeth, lower teeth. Just think teeth. Just think the teeth as the boundary of oral cavity, beta. Up to the teeth, upper teeth, lower teeth. Okay. Can you see upper teeth, last tooth? Last tooth, beta. Okay. Can you imagine a line over here, beta? Line over here. Can you see the last tooth of the lower one, beta? Okay. Now, in front of this is oral cavity. Behind this area, this uvula, soft palate, behind this area is oropharynx, beta. Okay. Now look at screen, beta. This is the real picture of oropharynx. Now this is what the oropharynx is. In front of this oral cavity. Now mind you, hard palate. Look at me, beta. Hard palate, teeth wala part, oral cavity. Soft palate, oropharynx. Anterior 2/3 of tongue, oral cavity. teeth wala part. But posterior 1/3 of tongue, this last part of the tongue, posterior 1/3 of tongue is oropharynx, beta. Tonsil is a part of oropharynx. Uvula is a part of oropharynx. There are two pillars of tonsil, anterior pillar, posterior pillar, oropharynx, beta. Okay? So everything is oropharynx. This is a picture of oropharynx, beta. Okay? Now let us read your notes and let us see various parts of pharynx, beta. Oropharynx, beta. Understanding is very important, beta. Then only you get, now I know, oh, it has following parts, beta. Look at this picture, beta. Okay? Number 1 is soft palate. Number 1, soft palate. Oh yes, I remember hard palate is oral cavity, soft palate is oropharynx. Uvula. Everybody keep looking at this picture also, beta. Number 1, soft palate. Number 2, uvula. Number 3, beta. Look at this, number 3. Can you see pillars, beta? There are interior pillar, posterior pillar. Between the two pillar, there is tonsil, beta. Number 3 is anterior and posterior tonsillar pillar. And number 4 is tonsil. I told you the throat tonsil is a type of tonsil, and this tonsil is actually called the palatine tonsil. Palatine tonsil. The actual throat tonsil is a type of tonsil which its complete name is palatine tonsil. Okay, beta? Palatine tonsil. Now, next one. Posterior 1/3 of base of tongue, beta. Can you see posterior 1/3 of base of tongue? Yes. Posterior 1/3 of base of tongue, beta. I told you anterior 2/3 of tongue, oral cavity. But end of the tongue, posterior 1/3 of tongue is the oropharynx, also called as base of tongue, the end of tongue, base of tongue, or posterior 1/3 of tongue is part of oropharynx, beta. Okay. Now number 6, beta. Lingual tonsil. Can you see? On the tongue, number 5 is the tongue, posterior 1/3 of tongue. On the tongue, there are some lymphoid tissue deposits. This is called number 6, lingual tonsil. Again, tonsil means lymphoid tissue. Even tongue has got some lymphoid tissue at the end, and that's called lingual tonsil, beta. Okay? And number 7 is the posterior pharyngeal wall, beta. Number 7 is posterior pharyngeal wall. Look at screen, everyone. This is posterior pharyngeal wall, beta. Okay? Everybody, can you tell me what is this, beta? This is U, mane. What is U, beta? U is what? Uvula. What is SP? Soft palate. Yes. What are these two, beta? These are two anterior and posterior tonsillar pillars. Between the two pillars, there is what? Tonsil, beta. Okay? Tonsil. What is this, beta? This is base of tongue or posterior 1/3 of tongue. On the base of tongue, we have got small lymphoid tissue called lingual tonsil. And this is called number 7, beta. Number 7 is posterior pharyngeal wall. Can you see, beta? This is posterior pharyngeal wall. Behind this is vertebra, beta. Everybody imagine posterior pharyngeal wall. Behind this is what? Vertebra. Okay, fine. This is oropharynx, beta. I'm clear. Number 8, beta. Yes. One more thing is there. Right now, number 8. That's a question also. Number 8 is vallicula. Number 8 is vallicula. Right on vallicula. Vallicula is MCQ, beta. Put a star. Vallicula is the question. It is space between base of tongue and epiglottis. Vallicula, what is vallicula? It is space between base of tongue and epiglottis. It is space between base of tongue and epiglottis. Base of tongue and epiglottis. Now, what is this base of tongue and epiglottis? Oh, epiglottis, day before yesterday. Base of tongue we saw today, beta. Okay. Vallicula is a valley, beta. Look at my hand, beta. Look at my hand, beta. When the base of tongue ends in your throat, epiglottis seems to start over there, beta. Epiglottis is a leaf-like cartilage. When the base of tongue ends like this, epiglottis is starting like this. There is a valley between them. There is space between the base of tongue and epiglottis, and that valley between the epiglottis and base of tongue is called vallicula, beta. Vallicula, vallicula. Okay, let me try to show you this one if possible. Everybody, please look at the screen, beta. Can you see, beta? This is your oral cavity, beta. Can you see anterior 2/3 of tongue? Can you see the last tooth over there? Can you see the last tooth over here? Here. What is it, beta? This is what, beta? This is what, beta? Uvula. Can you see soft palate? Can you see two pillar, anterior pillar, posterior pillar? What is it, beta? Tonsil, beta. Once again, beta, please see. Please see, beta. Oh, soft palate, uvula, one pillar, anterior pillar, one this pillar, posterior pillar. Between the two pillars, there is what, beta? Tonsil. What is this, beta? This is base of tongue. Base of tongue, also called a posterior one-third of tongue. It has got small lymph tissues, which are called lingual tonsil. The lingual tonsil, beta. Okay, fine. Now let me take you further, beta. Oh, वो नीचे कुछ दिख रहा है? Can you see below there in the well? कुएं के अंदर, in the well. What do you see over there? A leaf-like structure. Can you see over there? Oh, it is written there. What is that, beta? This is what? Epiglottis, beta. Can you see? This is the base of tongue. This is the epiglottis. Can you see this space over there? This space is called vallicula. Vallicula, beta. This is the base of tongue, the epiglottis. This is vallicula, beta. Okay, once again, let us see from this angle also, beta. Okay, let us go from this. Oh, yes, I can see that. Oh, this is the base of tongue, end of tongue, beta. Okay, and this is the epiglottis. This valley between the two, this is called vallicula. Okay, vallicula is a part of oropharynx, beta. I hope you could conceptualize. Okay, are you learning it or not? Please write in the chat box. Are you able to conceptualize? Because all these things in my MBBS days, I could not even conceptualize. What the bloody hell is pariform sinus? What is vallicula? It was very tough for me, honestly speaking. I could not conceptualize anything. I hope you are able to understand, beta. Before you jump into your PG and all that, you have some clarity. Share your thoughts on this in the chat box. Are you able to understand the concepts in a proper way or not? Okay? Now, next question, beta. Vallicula, please do remember vallicula, beta. Now, bed of tonsil. Next topic, beta. Bed of tonsil is made by superior constrictor muscle. I hope you remember the tonsil, in the part of pharynx. Pharynx are three muscles: superior constrictor, middle constrictor, inferior constrictor. Bed of tonsil. Look at everybody, touch your bed of tonsil. This is your bed of tonsil. This is your bed of tonsil. Bed of tonsil is made by superior constrictor muscle. Bed of tonsil is made by superior constrictor muscle. Now, styloid process and glossopharyngeal nerve lie in bed of tonsil. Styloid process and glossopharyngeal nerve lie in the bed of tonsil, beta. Everybody draw here, beta. This is a normal side, beta. Everybody draw. Styloid process. This is the ninth nerve, beta. This is a normal picture, beta. Normal. This is normal, beta. Draw a line. Normal. Okay? This is disease, beta. Disease. Okay, have you drawn it, beta? So please see, normal people, two things are here. Everybody touch your bed of tonsil. You should know as a doctor, this is your bed of tonsil. This is your bed of tonsil. Please know it as a doctor. This is my bed of tonsil, my dear friends. Okay? My bed of tonsil is this one. You should know. When you have tonsillitis, where is the pain? Pain is here. This is the bed of tonsil. It is made by which muscle? Superior constrictor muscle. Now, two structures are here. One bony process called styloid process. And which nerve is here, beta? Glossopharyngeal nerve, ninth nerve. Now, what happens in some people, disease, beta, styloid process become very long, beta. Styloid process become very long. Can you see? Styloid process become very long and it start pressing which nerve? Ninth nerve. Glossopharyngeal nerve. Styloid process which is getting elongated and it is pressing the ninth nerve, that will lead to throat pain referred to ear. Throat pain referred to ear, beta. Okay? Can you see, beta? Long styloid process touching the ninth nerve. Okay? This will lead to throat pain referred to ear. It's a disease. This is a disease, beta. It's a disease. It's a disease called eagle syndrome. Oh. Eagle money? You know, eagle bird. Eagle syndrome. This is called eagle syndrome, beta. Eagle syndrome. Eagle syndrome is MCQ. Beta. Now, how to remember eagle word? Beta? Eagle. Everybody, how to remember eagle word? Beta? Eagle syndrome. Look at screen. Beta. Can you see eagle beta over here? Have you seen eagle while flying? With its sharp claws, it holds a snake and flies away. Okay. Now, can you see over here? The sharp claws of eagle represent the styloid process. Okay. And the snake represents the ninth nerve. Beta. The snake represents the ninth nerve. Beta. Can you understand? The sharp claw of the eagle represents the styloid process, which is elongated. It's holding the snake, and the snake is representing the ninth nerve. Beta. So just to make a story, eagle syndrome, eagle has a sharp claw, and with the sharp claw, it holds the snake. The sharp claw represents the long styloid process, and the snake represents the ninth nerve. Beta. And this is eagle syndrome or styalgia. So you have a styloid process, yes. You have a glossopharyngeal nerve, yes. But in some people, the long styloid process can press the ninth nerve, and that leads to throat pain referred to ear. Very good. Okay. Now, let's go further, beta. Can we go further? Let's go tonsil, beta. Tonsil is equal to palatine tonsil, beta. Tonsil is equal to palatine tonsil. Okay, palatine tonsil. Tonsil is equal to palatine tonsil, beta. Palatine tonsil, beta. Palatine tonsil. Now, please understand, tonsil has capsule, it has crypts, and it has definite blood supply, beta. Everybody underline, tonsil has capsule, crypts, and definite blood supply. Oh, I am able to recall something. What? Adenoid is same lymphoid tissue, but adenoid has no capsule, no crypts, no definite blood supply, beta. But tonsil is same lymphoid tissue, which is more organized. It has got capsule, it has got crypts, it has got definite blood supply. You say, Rajiv, what the hell is crypt, beta? Now look at this picture, beta. Look at this. The tonsil surface is not smooth, it's corrugated. Corrugated, beta. You say, Rajiv, where is the actual crypt in the real life, beta? In the real life, where is the crypt, beta? This is the look of this is the tonsil, beta. This is the tonsil area. Okay, let me change the color. This is the tonsil area, beta. This is the. Do you say, Rajiv, still crypts are not visible? Don't worry, I brought something else for you. Can you see, beta, over here? This is the tonsil and this is the crypt. Can you see crypts, beta? There's small depression in the surface of the tonsil, beta. Can you see crypts, beta? Crypts. There, can you see the arrow, beta? So there are crypt in depression like that. Okay, surface got in, the epithelium goes inward like that. Okay, there is one crypt which is deepest, and the deepest crypt is called crypta magna. Look at the notes, beta. The deepest crypt is called crypta magna, beta. The deepest crypt is called crypta magna. Okay, one crypt goes very deep, and that is called crypta magna. Okay, the main blood supply of tonsil. Very last time question of MCI, beta. Main source of blood supply of tonsil. Write down, beta. It is tonsillar branch of facial artery. Is tonsillar branch of facial artery, beta. This was the last time question of MCI, beta. Very important question, already came. Repeat question, tonsillar branch of facial artery. The main blood supply of tonsil is tonsillar branch of facial artery, beta. Tonsillar branch of facial artery, okay? Tonsillar branch of facial artery. Next is venous drainage of tonsil, beta. Paratonsillar vein. Paratonsillar vein, beta. Paratonsillar vein. Paratonsillar vein, beta. Paratonsillar vein, beta. Paratonsillar vein. Paratonsillar vein. Okay. Now, what is the signal of this vein? This vein is the main source of bleeding during tonsillectomy. You know, tonsillectomy is a bloody surgery, but it's a lot of bleeding happen during tonsillectomy. But the main source of bleeding is not arterial, it's venous. And the main source of bleeding during tonsillectomy is actually the paratonsillar vein. Paratonsillar vein, it's the main source of bleeding during tonsillectomy. Oh, fine. Let us see the tonsil once again. Tonsil, the complete name is palatine tonsil. Tonsil has got capsule, it has got crypts, and it has got definite blood supply. Crypt depression like that. And the deepest crypt is called crypta magna. The main blood supply of tonsil is MCI question, tonsillar branch of facial artery. The venous drainage of the tonsil is paratonsillar vein. It is the main source of bleeding during tonsillectomy. I was trying to tell you that tonsillectomy is a very bloody surgery, beta. It's very bloody surgery. A lot of bleeding happens during tonsillectomy, and you should know that this is your this is not this ablation. This one. Please see, this is the tonsil being done. No, not this one. This one. Please see. Can you see somebody is holding a tonsil? Somebody holding a tonsil with the tonsil. This is the patient under anesthesia. What is the name of position? Rose position. What is rose position? Neck extension. What is the same position used for adenoidectomy? The same position is used for tonsillectomy. Can you see tonsil? Laddu, beta, laddu. Okay. Now you are giving a cut on the anterior pillar of the tonsil, beta. You want to separate the tonsil from its bed. It's tonsillectomy being done. Tonsillectomy. Okay. What is the name of surgery right now being done? Tonsillectomy. You're holding tonsil with the forceps and you're trying to separate the tonsil from its bed. But you will see continuously some bleeding will be on. And you will have to put a cotton over there to press it. Cotton over there to press it, beta. To control the bleeding. And you do the surgery. You separate a tonsil from its bed. Can you see tonsil is being separated from its bed? Can you see the laddu is coming out? Laddu is coming out, beta. And then you separate the laddu completely, beta. Oh, can you see, beta? You have separated the laddu completely. Now you pass a wire around that. This is called snare. Snare, beta, snare. And then you apply the snare. Can you see the wire, beta? Wire. You want to just crush the base and cut it now. This wire is called snare, beta. Then you put that wire around the bed of the tonsil, beta. Please see, again snare. This is snare wire. And then you just go there, tighten it. And you have to bring the laddu out, beta. Okay, laddu is the tonsil, beta. Can you see the wire there, beta? Can you see the wire there? This wire is there at the end of the tonsil, beta. You are trying to cut the pedicle now. Okay, now you're holding the tonsil. And now please look at my hand, beta. You're applying the force on the wire. Cut, and final pressure comes. Tuck sound comes and laddu comes out, beta. And this is laddu comes out, and then the bleeding has to be controlled. Or this bleeding, put a cotton over there, put a stitch over there to tie the vein, beta. Okay, you have to apply a stitch to tie the vein, and this main source of bleeding is what? Is the paratonsillar vein, beta. Now the next topic, hemorrhage in tonsillectomy. Hemorrhage in tonsillectomy, beta. On the sidebar, write down. On the sidebar, write down. On the sidebar, everybody write down. Tonsillectomy, most common method. Most common method of tonsillectomy. On the sidebar, write down. Tonsillectomy, most common method. Most common method is dissection and snare method. You dissect it, and what is the name of the instrument? Wire, beta. Wire, what is wire called? Snare. Dissection and snare method. A very simple concept. First you dissect the tonsil from its bed. Then you apply that wire at the end of the tonsil to cut that pedicle of tonsil, and that wire is called snare, beta. Snare wire. Dissection and snare, S-N-A-R-E. What was snare? Snare means that wire which you use to cut the pedicle of the tonsil. Okay? So dissection and snare method is the commonest method used for tonsillectomy. Problem with tonsillectomy is a lot of bleeding happens, beta. There are 3 types of hemorrhages, beta. Everybody, there are 3 types of hemorrhages. 3 types of hemorrhage, beta. Primary hemorrhage, reactionary hemorrhage, secondary hemorrhage, 3 type of hemorrhage, and 2 MCI question. Can you imagine such a high yield question, beta? 3 hemorrhages and 2 MCI question, beta. Primary hemorrhage, reactionary hemorrhage, secondary hemorrhage. Now let's understand, beta. Hemorrhage in tonsillectomy is of 3 types, beta. Primary is during surgery, beta. Whatever bleeding you saw during surgery on the screen, primary hemorrhage. You controlled it with the stitch you applied. You tied the vein with the cotton pressure. You controlled the bleeding. Patient came out of the operation theater in the ward now. If again bleeding start in the ward, when the patient has been shifted out of the operation theater, that's called reactionary hemorrhage. Reactionary is, write down in the bracket, it is post-operative hemorrhage. Within 24 hours of surgery. You send the patient to the ward in the afternoon. At night you got a call. Doctor, nurse calls, she's scared. Doctor, the patient is bleeding from mouth. At night. You operated in the afternoon, bleeding started in the night.
within 24 hours surgery. It is due to slippage of ligature. Ligature means stitch. You used a stitch to tie that vein, beta. You applied a ligature. Ligature means stitch. Stitch means silk stitch, beta. Okay, suture. You applied that suture to control the bleeding of the vein, but that stitch was a loose stitch. It came out. It's an emergency. Patient is puking blood, vomiting blood, beta. It's an emergency. It's an emergency, beta. It's a big emergency. It's an emergency. Okay? Treatment is re-exploration. Don't worry, we'll control it, beta. Re-exploration. Matlab, reapply the stitch. This is MCI question, beta. Re-exploration. How to remember it, beta? R-E-R-E. Reactionary, re-explore, beta. How to remember it, beta? R-E, reactionary, R-E, re-explore. Kabhi galat nahi hoga. This question will never go wrong, beta. Reactionary hemorrhage, re-explore. Reactionary hemorrhage, re-explore, beta. Reactionary hemorrhage, re-explore. Re-explore means reapply the stitch, beta. It's a serious emergency, beta. It's a patient is vomiting blood. Re-explore. Apply the stitch again, beta. Then is secondary hemorrhage. Again, post-operative. After 24 hours, any bleeding is secondary, beta. Mostly after 5th day of surgery, yes. Patient comes back from home. The clue is patient has already gone home. You know why? Tonsillectomy, we discharge the patient next day maximum. We just keep it for one night. Sometimes we don't keep it for one night also. Patient has gone home. After 5th day, he comes back to the hospital. Doctor, I'm bleeding from the mouth. Now, what is the cause, beta? Cause is infection of tonsillar fossa. The tonsillar fossa, that gadda, from here you remove the tonsil, that got infected. Sometimes patients do not take care, beta. They don't do gargles. The children don't do gargles, betadine gargles. They don't do that. You tell them eat ice cream, don't eat anything hard. They order biryani. They open up Zomato. There's an offer over there. 1 for 1 biryani free. You know, can you understand, how tempting it is? Hyderabadi biryani, you know what? Bawarchi biryani, Talapkati biryani of Chennai, you know what? They're like, you will order biryani and the biryani rice will get stuck into your tonsillar fossa and pus will form over there. But fortunately, it's a mild bleeding. Right on the side, it's not a serious bleeding, beta. It's a mild bleeding, beta. It's a mild bleeding only. It's a mild bleeding only, beta. It's a mild bleeding. Treatment is readmission. Oh, admit the patient back and intravenous antibiotics. Very important question. Readmission and intravenous antibiotic, beta. You have to inject infection, huh? It's a mild bleeding, beta. Doctor, it's not vomiting blood. Doctor, when I spit, there's a red color in that spit. That's all. Doctor, when I spit, there's a red color in the sputum. This much blood, little bit blood. Mild. Patient will not die of this problem. This reactionary was serious problem. This is just a mild bleeding. Admit the patient and start intravenous antibiotic. Okay? Can we revise this hemorrhage, beta? It's important topic, beta. Let us revise the hemorrhage. What are 3 type of hemorrhage, beta? Bolo, beta. 3 type: primary, reactionary, secondary. Primary, during surgery. Reactionary, post-operative, within 24 hours surgery. It is due to slippage of ligature. It's an emergency. Treatment, re-explore, beta. RE, reactionary, RE, re-explore. Number 3, secondary hemorrhage is again post-operative after 24 hours, mostly 5th day after surgery. Patient comes back from home and it's a mild bleeding. It is due to infection of the tonsillar fossa. So readmit the patient and start intravenous antibiotics, beta. Start intravenous antibiotic. My dear friends, is it clear to all, beta? Start intravenous antibiotic, beta. Intravenous antibiotic. Everybody, just let me tell you how the question can come, beta. Now read it, beta. Read it, beta. This question of hemorrhage, how it can come. Let us see. Let us see. Oh, yes. Let us read this question, everybody. Read with me. Let me read it for you. 17-year-old male patient underwent tonsillectomy on Monday. Monday. The first day of the week he got operated. Monday. He operated on Monday. Okay. His post-operative period was uneventful. So he got home. He was discharged on next day. Went home. On Sunday morning, Monday got operated. Sunday morning, he presented in emergency with complaint of mild bleeding, beta, from oral cavity. First of all, tell me, what type of hemorrhage it is? Reactionary, primary, secondary. Monday you got operated. Sunday you presented to the emergency again with mild bleeding. Can you tell me what type of hemorrhage? Write in the chat box, beta. Primary, reactionary, secondary, beta. Everybody, can you write in the chat box? Yes, it is secondary bleeding, beta. It is secondary hemorrhage. What is the answer? Admission and antibiotics. What is the answer, beta? Admission and antibiotic, beta. What a choice. It's normal to have mild bleeding? No, it's not normal to have bleeding after 7 days, beta. Admission and re-exploration, never do that. Oral hematinics, why to give hematinics, beta? Iron, why to give iron, beta? Can you solve this? Looks like a scary question, but when I know the logic, could you answer this question? Tell me in the chat box right now. Could you answer this question? This question was looking scary question, long question, but when we know the story, we know the answer, beta. We know the answer. Monday you got operated. Sunday you are bleeding again after 24 hours, mostly after 5th day. And other clue is mild bleeding, beta. Mild bleeding, and treatment is readmit the patient and antibiotics, beta. Okay, is it clear? Everybody, no problem? Okay, fine. Could you answer this question or no? Okay, fine. Let us do, what's the time? 11:35. Just let me see how much is left, then we'll see. Okay, fine. Let us take a break here. It's a 15-minute break. We start again after 15-minute break. Okay? In the break time, come on the chat box and write down, how are you doing? How's the day going for you? Let us talk, let us discuss, let us be connected. In the break time, in the meantime, when you're making coffee or something, just pick up the chat box and write how your day is going. Are you learning? Are you having fun while learning? Are you conceptualizing? Are you able to see the question and able to relate to them? I'm not saying that you're memorizing it. I'm saying, are you able to understand the concept or not? Memorizing is a later on affair. Okay?